Well, welcome, both in person and online participants. It's really lovely to see you all on this gorgeous day. And I'm very happy to welcome, well, really, an old friend and mentor and colleague, Professor Sarah Hawks, who's going to present on her work as the co-lead of the Lancet Commission on Gender and Global Health. I'm going to have to read this because both her own background and Jurger's background, my colleague Jurger Edstrom is going to act as a discussant. I want to be sure I don't miss the key aspects of their biographies for this moment in time, because I tend to be informal and just talk to people about, Sarah and Jurger, but these are really esteemed colleagues who've done incredible work in the space. And we were very lucky, especially as Sarah's traveled from Malaysia, not just to be here at IDS, but was willing to make a stop here amongst her UK tour at the moment. So Professor Sarah Hawks is the co-chair, like I said, of the Lancet Commission on Gender and Global Health, the co-founder and the co-CEO of Global, is it Global 50/50?
It is.
It's now Global 50/50, new name, and the head of Global Population Health at Monash University in Malaysia. And she came to the work of the Commission, as you will learn about, through many years of multidisciplinary work in sociology, epidemiology, medicine, and her work really sits at the interface of research and advocacy for social policy and health policy in pursuit of social justice and fairness. It's very equity-centered work and significant work on gender equity and global health. So thank you for coming, and we look forward to your talk. And then we also have my colleague Jurger Edstrom, who's a research fellow in the Power and Popular Politics cluster. And he has been invited to discuss it because he also has a very long track record, 2 decades plus work as a development social scientist focusing on gender equality, men and masculinities, gender-based violence, and sexual and reproductive health and rights. But more sort of pertinent to what we're going to talk about today, since 2019, he's led a CETA-funded Countering Backlash Initiative, which is a multi-country research program on anti-feminist and anti-gender backlash. And as for myself, I'm Erica Nelson. I'm a research fellow in the Health and Nutrition Cluster. I was lucky enough to contribute as an author to this commission, and over the 5 years of its life, it was an incredible learning opportunity to be part of the process. So I'm going to turn it over to Sarah so you can all hear what great work is contained in this commission. So over to you, and thank you.
Thank you, Erica.
You're good.
Right, you hear me, can't you?
You'll be back.
I'm going to move over to where I can actually put the slides forward. So, Erica, thank you for the introduction, and obviously a huge thanks for inviting me here. But mainly a huge thanks for keeping me calm over the past 5 years through what turned out to be quite a challenging process in many ways to bring this Lancet Commission to fruition. And so we started the commission in March 2020, and if you could sort of throw your minds back to March 2020, you'll remember that it was probably the worst time in the world to start the process of a commission on health, because everybody's attention was obviously focused just on the pandemic. And these commissions, I don't know how many of you have ever been involved in a Lancet Commission or this kind of a process, but they are very challenging in many ways. They're also, gotta love the mechanism of the publishing industry and how they get everybody to do a lot of work for you for free. So there's no money that comes with running a Lancet Commission. You have to find the money yourself. And in trying to find the money at the start of the global pandemic, we were just met with a lot of resistance and no funding until Wellcome gave us a very gratefully received but rather small pot of money to do what turned out to be 5 years of work. And I'm telling you all of this just partly as an excuse as to why it took us 5 years. But also the 5 years, as you will see as I go through, represents what turned out to be a very challenging time in trying to get agreement, even amongst 25 commissioners and authors, as to what gender actually is and what it means for health. And that's okay. Great, thank you. Great. So the commissioners and authors, we kind of deliberatively chose to work with people who are from the gender field, so gender specialists, often people who are gender specialists in the health field, but then people from the other parts of health that are specialists in their own area. So people who are specialists, for example, on the commercial determinants of health or climate change and health, to try to get them to think about what would it take to make people working in those health areas be more cognizant and responsive to gender. So what we were trying to do, in other words, was bring together not just a group of gender specialists, because gender specialists talking to each other don't necessarily tend to make many waves across the rest of health. But we also brought together a truly transdisciplinary group, which in and of itself was, as you all know, I'm sure, a very challenging thing to do. So we had historians, and anthropologists, and sociologists, economists, political scientists, a few biomedical people thrown in there as well. So people coming with very, very different conceptions of what the issue was, the issue being gender. We didn't even dream of addressing the issue that some of you might want to talk about, what is global health? That would take us another 5 years to figure that one out. But this group of commissioners and authors also represents, as you can see, a pretty good global spread. But it's also people involved in programmatic work, decision makers at quite senior policy level, as well as people from civil society. And one thing we did manage to do was get money from the Ford Foundation to do a program of public engagement with groups of young feminists across several African countries, across several countries in South and Southeast Asia. So, and we had an ongoing series of public engagement through webinars and seminars, as you'll all remember during the pandemic years when everything had to be online. So it was, as far as we could make it, quite a collaborative process, but we can certainly get into where collaborations become very challenging when you start to talk about gender. But as you'll see, we also, we try to encompass a whole range of people with different gender identities as well, to really try to get in as many perspectives into the commission as possible. And we started off by just trying to figure out how does global health and the global health system, when I talk about it now, I'm talking about the institutions predominantly of the multilateral system, of the bilaterals, the development partners, as well as national governments and national level delivery implementing partners. How do they currently understand gender and its relationship to health? And let me just say that all of the really, I hope you agree, very beautiful images that you're going to see threaded throughout the slides. As you heard from Erica, well, Lindsay and I, Lindsay sitting in the front row here, she's another one of the authors, work for Global 50/50. I work part-time, Lindsay works full-time. One of the things we do in Global 50/50 is run an annual image competition. So everything you see is from our annual image competition, which we'd be very pleased to tell you more about later, should you be interested. So what we knew, seem to have reached a standstill there. Thank you. What we knew is that the health field tends to think about gender identity and its relationship to health outcomes. So there's thousands, gazillions of papers out there that take an approach of describing a population divided by gender identity, often along binary lines, occasionally along thinking beyond the binary, and putting that in relation to health outcome differences. So here's classic kind of example that we present in the report. What this shows you those of you that aren't epidemiologists, I'll just very quickly explain that the slide on the left-hand side is global current smoking prevalence, and it's mapping male smoking prevalence against female prevalence, and the dotted line is where male and female at individual country level are smoking the same amount. And you can see that smoking is a totally male dominated behaviour in every country of the world, in every economic region of the world. Whereas obesity flips the other way. So obesity at a country level, at a national level, is a female dominant problem. Okay, and that's how the health community thinks about gender if it does think about gender, is to present it in terms of health differences. What we did in the report and what we've been doing in Global 50/50 is to take that kind of data and think not just about risk factors or mortality outcomes, but to put it in a pathway from risk factors to outcomes of mortality, and show where there are differences between men and women for every country in the world for 3 conditions. And again, we go into all of that in the report itself. The other area that the health community works on quite a lot is around gender and the health workforce. And when you look at the report, if you have time, you'll see that we go into the history of the gendered health workforce, that this is a sector that has always had very gendered divisions in terms of who gets to be in the caring side of health services. So that's women going into nursing or professions allied to health, whereas traditionally men have become the leaders of health systems and the health sector, and up till very recently, certainly within my lifetime, the medical profession was dominated by men. And we show in the report that notion, that very Victorian notion of this gendered set of occupations, was essentially transplanted around the world through colonial exercises in replicating the health systems of Victorian Britain into colonial settings. The work we do in Global 50/50 shows that not only is the global health sector, so this is 200 organisations that we look at every year, not only is it still predominantly led by men at the most senior level, but those men come from a very, very small and select geographical entity. They come predominantly from the US, to a certain extent from the UK. So if you look at board membership across 150 organisations, amongst 1,300 board seats, only 2% of those board seats are held by women from low-income countries. So these are the kinds of data points that the health sector is very used to talking about. So what we then did in the commission was look at where do those biases, where do those ideas about what gender is and what gender identity is, where do they come from in health and how they're used? And one of the things that we saw, first of all, is that gender is often misunderstood, either to mean just identity or to mean sex, which is kind of funny, really, when you think about that here's a group of people very concerned with looking at the human body, but very unable when reporting on the human body in research papers or journal articles, for example, to make a distinction between gender identity and sex. Two terms are very, very frequently conflated. It's not just in the academic sphere that we see that conflation. What I'm showing you here is questions from the World Health Organization survey this is the global school-based student health survey. We looked across, I think, 8 or 9 global surveys to see, run by WHO, the World Health Organization, say how do they ask about gender identity in those surveys. And so the school-based survey, as far as surveys go, trying to find out about gender identity, this is probably one of the better examples. how you describe your gender identity, male, female, non-binary, some other way, I'm not sure, I don't know what the question's asking. So pretty comprehensive set of options for students. Whereas the tobacco survey doesn't ask an individual, it just asks the enumerator to decide what the gender identity of the respondent is, are they male or female. In publishing, what we saw through scoping reviews and through analyses of published papers over a 6-month period in the field of HIV and STI, sexually transmitted infections, a field that has quite a long history of looking at issues of gender and gender identity, we saw this is actually a table that I took out of a paper on the plane yesterday. So this is a paper published a couple of weeks ago. I randomly chose an AIDS journal, took the very first paper that showed us data, and it completely conformed to what we saw in all of the other papers that we looked at for the Commission. What you see in terms of how gender is thought about in health work is you get something about, you get a question about gender identity, male, female, transgender. Only a couple of the papers we looked at had something about transgender identity. So this is a very typical table 1 in a biomedical paper, right? Here's the demographics of the population. But by the time we move to table 2, everybody, which is around risk factors, everybody just gets collapsed into one. There's no disaggregation of gender identities anymore. Nothing beyond table 1, demographics. By the time you get to the discussion and the conclusion, gender disappears entirely. There's never any discussion at all about gender as a system or structure and what that might mean for the results. The most we can hope for is something about who's actually in your study. The next bias we saw across global health in particular is that when we're talking about gender, we're talking about women and girls. So work that was done and incorporated in the Commission, again by Global 50/50, we looked at those 198 organisations, and we looked at the population focus of these global health organisations. And you can see the data there, 174 of the organisations have some kind of focus on gender equality, 10% recognise the needs of trans and gender diverse people, only 3% recognise the health needs of men and boys. So across the global health sector, we've got a very narrowly focused vision of what gender means in relation to health in terms of the populations that we're trying to reach. This data here relates to one country. It kind of doesn't matter which country it is. This is, again, a very typical story. These are the data from alpha alcohol use amongst adults in this country. And you can see, again, you saw that in the first slide I presented, alcohol, like tobacco, is a male-dominant behaviour. Drug use, injecting drug use, is also typically a male-dominant behaviour. But the national policy for the country says we will focus on women because of their unique needs and degree of vulnerability. That's a really common mismatch in terms of where the empirical evidence of risk or behaviours or problems lie and how policies actually respond to that. The third bias that we saw in setting the scene for the Commission is that gender doesn't really affect most health outcomes. What we're talking about when we talk about gender is sexual and reproductive health. If you're lucky, we might be talking about HIV, but beyond that, we're not really talking about all other health issues. So how do we get to this very narrow, misunderstood, misaligned, misinterpretation of what gender actually means within the health sector? So thanks to the work of Erica and a number of research assistants who went through over 700 documents, both at the global level and the regional level and some national level documentation to try to figure out the kind of the historical development of how the global health sector has ended up with this vision. And I'm presenting a very narrow snapshot of a much longer timeline that Erica has beautifully laid out in the Commission's report going back to the 1940s, but putting it in the context of going back to the 19th century as well, to show that as health, health is in some ways a typical part of the development sector, has really only ever talked about gender in relation to women. So hence the emphasis on the World Conference on Women, for example. Selective primary healthcare, which came about 1 year after the Alma Ata Declaration of Primary Healthcare for Everybody. Selective primary healthcare narrowed the focus to only focus on women and babies. And we don't actually see the word gender appearing in the global health sector until the early 1990s. So it's not until 1993 that the Tropical Diseases Research program within WHO actually comes out with a report on gender and tropical diseases. It's the first time that the word is introduced. The following year, of course, we had Cairo, ICPD, and I'll show you in a minute how gender is talked about in Cairo, which was a bit of a surprise to all of us. And then we start to see the development of gender strategies, but nobody ever really sets out what does gender mean. And so I will come to what that results in during the course of the Commission in a minute. What we saw, what Erica saw, is that actually ICPD never defined gender. So it introduces this concept to the world. Brilliant. You know, we're going to now talk about gender equality, we're going to talk about sexual and reproductive health, we're going to introduce all of these very progressive ideas. But when it comes to actually defining gender, Annex A, I think, it says go to Annex A, we'll define gender, and it's literally as in its ordinary, generally accepted usage in your country. That's the definition of gender. So you can, I'm sure if I asked all of you what does gender mean, well, perhaps not, because you're all sitting in IDS and you're the people. But you've probably all got slightly different ideas. I mean, that's what we discovered amongst the 25 commissioners, is actually everybody has a very slightly different idea about what gender means. So generally accepted usage is not terribly helpful as a global definition moving forward. And these organisations, they fight amongst each other the entire time that Erica's looking at all these documents in that entire, it's a fight, it's a discourse fight, it's a language fight, and obviously that's a representation of an ideological fight. And it really reaches a pinnacle in 2022 when it came to approving the HIV, STI and hepatitis strategy at the World Health Assembly, which takes place at this time of year. When we ended up in a situation where 90 countries walked out of the room rather than approve a strategy that talked about gender. And only 60 countries approved the strategy, 60 out of 193. So we've got this incredible, intense, ongoing fight about what does gender mean. So several of the people on the Commission were lawyers, looked at the question, can international law, if we go look at international treaties and covenants and statutes, will that give us any clarity? But it turns out that no, there's never been any agreement at the level of international law as to what gender means for any of us. And we've seen the trouble that happens when the legal sector steps in to make a definition. But in the absence of a definition, we have no guardrails around what gender means for this global sector. So this is where we ended up with the Commission's understanding of gender and concepts of gender justice to try to sort of put our stamp on what it is that we're talking about. And it's a very long definition. If I go to the WHO web page. It's a very short definition, I know, because I wrote it back in 2015. Another process that took 5 years to get countries to approve about 3 sentences through very slightly banal sentences around it's about social construction, etc., etc. But here is gender as we define it in the Commission. So it's about the structure of social relations and practices organised in relation to reproductive bodies. Its gender relations affect everybody, even those not explicitly involved in biological reproduction, but are understood in relation to biological reproduction. It's not separate from biological reproduction. It involves the extensive interplay of social and biological processes. So this is the Commission's definition. And here's our definition of gender justice. And we're trying to get people to think that we're not just talking about gender equality or gender equity or gender parity and all of that counting that happens in biomedicine. We're talking about achieving a very, if you like, we're talking about actually addressing the deep-seated systems and structures that underlie why we see inequalities, why we see inequities. And at the centre of everything that we have described in terms of what it will take to achieve gender justice is an understanding that gender is about distribution of power in society. Again, no, I'm going to come here and preach to the converted, but for a Lancet readership, when we start talking about power as opposed to what can you count, that's a pretty revolutionary set of ideas in a very apolitical, atheoretical field of practice. So we go into several aspects of understanding power and its relationship to gender and health, and I'm just going to give you a couple of examples which I think are sort of the new contributions that the Commission is making in the field of gender and health. So one, I'm going back to that slide I showed you that what we often see is measurements of difference, and I'm showing you that this is data. I chose India because the last time I presented this data was in India, and we see these male dominant behaviours of smoking and alcohol, okay, that are very typical, and they're typical in as much as here's data from WHO, what you see along the bottom, these are the WHO regions. In blue, you see male smoking, in pink, you see female smoking. It's male dominant behaviour in every region of the world. The closer you get to gender equality at a national level, European region, and a little bit in North America, the closer you get to equality in smoking prevalence. Until by the time you actually get to Northern Europe, you see more girls smoking than boys, which is subject probably of a different talk, but it's to say it's a male dominant behaviour. Okay, and that's not surprising. We have had literally a century of people making money out of pushing cigarettes as something that men do, and the same with alcohol. So it's absolutely not a surprise to anybody who thinks about commercial manipulation of gender, that smoking then becomes something that men do because it's associated with all of these cool features of being a man smoking in India. You get to play polo, you get to ride on his bike, you get to hang out with cool sunglasses. And we know from looking at industry documents that given the success that the tobacco industry has had in pushing cigarettes as a male dominant behaviour, that they are now targeting the untapped markets of women in Asia and Africa as specific focus to get them now to start smoking. They want gender equality too, it turns out, in a different way that you and I might want gender equality. The other aspect of power and relations, gender and health that we looked at, and I very much defer to Jurka's expertise in this field, is the power of the anti-gender ideologues, and we can certainly discuss this more afterwards, but saying that we see the impact of what the anti-gender ideologues are doing again and again in the health field, particularly with an emphasis on what it means for rights in relation to sexual and reproductive health for everybody, but also what it means in rights in relation to aspects of maternal health and contraceptive health, and a large number of health areas being directly impacted by these groups that are prevalent everywhere. You know, we're I'm sure going to be able to talk in depth and at length about what's currently been happening or what we're seeing happening since January. But just to say that this has been going on for decades, and it's been going on in many parts of the world. So the report and the associated commentary remind us that we've seen this kind of discourse, this kind of impact, this kind of removal of the very term gender in several countries and several settings over the past 20, 30 years. But of course, we've seen it sort of at its absolute apogee happening in January with the removal of the very idea of gender, that now we're all back to thinking that this is just about biological sex. And so if you think that it's just about biological sex, and you think back to that slide I showed you with those differences between men and women in smoking and who gets to go to a health service and what the outcomes are, if you remove gender from all of that, you almost completely remove our ability to respond to things like, why do men smoke? Why do women not access health services? Why do health care providers, why are they more likely to give higher quality of care, higher quality services to men compared to women? You know as well as I do, that's not down to biology, that's down to gender. And so the immediate impact of the most recent executive order, the January executive order, is that in the US, we've seen the disappearance of huge numbers of data sets that mention gender. So we've seen the disappearance of youth behaviour surveillance systems, as well as large numbers of trans and LGBT websites. We've seen NIH withdraw millions and millions of dollars of funding to any program that talks about gender. But we've also seen, this is work that Lindsay's been doing, we've seen in Global 50/50 a collapse in organisations' commitments to DEI and gender equality. So between December and February this year, we saw about a 25% reduction in the 72 US-based organisations in Lindsay's sample, a 25% reduction in public commitments to upholding equality of opportunity for their workforce. Okay, so there's been an immediate chilling effect on the health sector of these executive orders. The final bits I just want to go into about holding the powerful to account. So if it's all about power, how do we hold the powerful to account? And what we saw through reviewing accountability mechanisms at the global level, at the national level, at the subnational level, is that there is a complete siloing of health accountability mechanisms and gender accountability mechanisms. So if you look at the health accountability mechanisms and the reporting mechanisms, they almost never talk about gender and gender justice as an element of what health people should be held to account for. And when we look at gender accountability mechanisms, very narrow view of what health is. We're only talking about family planning and violence against women. The one exception is the Framework Convention on Tobacco Control, which does have a regular reporting mechanism. And again, I know this because we wrote the report for the FCTC about 7 years ago, a gender analysis of tobacco control globally, an analysis that was widely praised, except when it came to voting, and Russia decided there was no such thing as gender, and hence blocked the entire report. So, but this is all by way of saying that we are existing in a world of despite the SDGs and their what was David Navarro's phrase? It was about the interlinked warp and weft of the indivisibility of the SDGs. Actually, when it comes to accountability mechanisms, we're not seeing any integration. So we've got lots of recommendations. I won't bore you with the whole lot, but I want to just flag up a few for your consideration. I'm very happy to hear you consider the others too. But the first is, do we need an international, global legal definition of gender? We've seen what happens when countries remove the term gender. Do we need to protect the term gender at a global level, and what that means, what that looks like? Everything around, we all need to start disaggregating our data, but I won't go into that. You've heard that for decades, because we all have. We need to absolutely support gender equitable career opportunities for everybody working in the health system. Again, you know, hardly rocket science. But I thought that you might be interested in some of the accountability and governance systems recommendations. So one is a hosting platform that brings health and gender reporting together into one single site. So you're not constantly having to go across the entire web to try and find out what the status of health and gender is. The other is integrating accountability mechanisms, pushing back against the anti-gender forces. I'm sure we're going to hear more of that, and managing the gender impacts of commercial determinants, something that oddly this country actually has tried to do through the Advertising Standards Authority, but very few other countries have taken on the commercial determinants of health from a gendered lens. And then finally, in some ways our most radical is a suggestion or recommendation is how we fund all of these, this huge table of recommendations. You probably know the concept of sin taxes. So this is taxes applied to health harming products, sugar, tobacco, alcohol, trans fats, etc. We're suggesting a ring fencing of sin tax funds, finances at national level to fund gender work in the health sphere. Thank you for your time.
Oh. Yes, please. I turn it up to you. Even from how you can go and do
You're going to be facilitating the discussion of what.
This is true. I guess she's sitting out. Yeah, it's not a position. Thank you, Sarah. And now we can turn the mic literally over to your Christian still beyond.
Thanks.
Here's some initial reflections before we go to the Q&A.
Yes, so thank you, first of all, Sarah and Eric for organizing this. A really interesting and congratulations for getting to the end of a long tunnel, and I'm sure the process was tortuous as well as filled with moments of joy and hilarity and all of that. So a lot to digest, and thanks for the presentation, which kind of sums up the gist of why this is exciting and important despite the current context of pushback and backlash. So, I mean, what I like, there's lots of things I like about it. And it's very clear that the Commission has had that kind of just the historical context of it. I think is really important here, and understanding how global health has come some way historically, gone through a lot of resistance as well along the way, but that is also fraught with considerable limitations and baggage, essentially, including the simplistic and contradictory treatments of terms like gender, as is very well noted in the Commission report. So that kind of package with its attendant, to use Maxine Molyneux's term, gender ennui, and which is now broader in terms of development ennui. Now that is, has on the one hand kind of materialized, individualized, and peopleized the issue of this particular social justice issue. And particularly so in health, as you explained well, and the report explains very well. On the other hand, it's also facilitated the right to essentially dismantle and defund. Well, I'm simplifying here, but it's facilitated the onslaught of the right to defund and dismantle health, as well as multilateral collaboration with global health very much in crosshairs. It's kind of a lightning rod almost, and within that, of course, women and reproductive health, sexual and reproductive health becomes a lightning rod. What I find really refreshing and useful in this report is it's taking terminology and framing seriously, which is, as you explained very well, all these declarations and lots of reports throughout the decades have assume that we have all understand and agree on what gender is. Clearly, we haven't. And that's a really refreshing take. And I think the 3 M's that also comes up, there's this comment article in the Lancet as well, which is quite useful because I believe that's sort of written at the end when the onslaught of the recent months has become more apparent, because of course a lot of this happened before Mark 2 in January 2025. And of course, like you showed, the reality has changed since then, even more. And there is the 3 M's in terms of, and you described kind of in terms of gender having been misunderstood to mean only sex, by many people, misrepresented, or sorry, misinterpreted, perhaps also misrepresented to mean only identity, and that has brought problems in its own right in many ways. And then finally, of course, it's been manipulated, profit, and for ideological goals by a range of actors since its introduction to the sphere of global health. I'm quoting directly from your comment piece there. And as you actually gave us your definition, the Commission's definition, which I find very useful as well, the structures, defining gender as the structures of social relations and practices that are organized in relation to reproductive bodies. Now, we need to think about that reproductive bodies, what that means, because of course that, and I think you explained that well, it leaves open. It includes multiple positions, roles, and identifications in relation to reproduction itself, going well beyond merely sex bodies that we often focus on in health, and recognizing people and their communities reproductive as being reflected in multiple complex ways, both relationally and communally. So it's a broader understanding of reproduction. I would like to believe that we were taking a broader understanding of reproductive bodies. I really enjoyed or appreciate identifying of the implications of these biases that you outlined. Many of us have written about those for many decades now, or a couple of decades at least. But it's felt like we've been shouting into the void. And it kind of underlines the resilience and the resistance of our institutions and our world. But that's relevant to health, and that then relates directly to your own framing of the analysis, which I appreciate. And it's kind of very comprehensive framing, looking at levels of this kind of onions, layers of a framework, reminiscent at least of a socio-ecological model. Not exactly the same, but reminiscent. And what is exactly the same? There are many socio-ecological models. So whilst that's very useful for identifying specific types of strategies at different levels and institutions and so on, it can also make it hard to trace the interactions between those levels and places, institutions, which themselves involve changes across different dimensions and geopolitical levels, across what our June Apparai calls these different types of scapes, stretching from local to local, finance-scapes, ethno, ideo, media, and technoscapes. And you talked about powerful ideologues. So, and of course, we have the divisive media, which really works transnationally as well as nationally. So I think we need to come up with creative frameworks and framings that can help us trace the influences, how this is working. Because of course, backlash actors have been very active in these different scapes, and different actors more so in different scapes. So some of the Musks and the hyper capitalists of different kinds are very active in the finance scape and reshaping our world for mass expropriation. The ideologues, sometimes faith-linked, or ethno-nationalists, for example, are very powerful. And so, though I appreciate, sorry, I'll give, yeah, not too much yet. Yeah, so I also agree. That takes me to, we really need to look at power, and of course, it's great, we are looking at power and accountability. That pushes the problem one step further though. How do we understand power? And that, I guess, and I'm not surprised, and I'm not, it's tall order, it's a big ask. And the health sector doesn't necessarily think about power very much. It's riddled with power relationships, of course, and we're familiar with those. So I guess I would encourage us to think about more creatively about what power is, and the fact that it's not always bad. There are many kinds of powers that we're within, and there are many ways to do power analyses, which are very familiar here at IDS, of course. Accountability for empowerment, and well, we have a program called A48.
Accountability for empowerment and action. No.
Anyway, so it's not binary, and of course, that is often a common problem when we talk about power, and when we write about power, we think of it as binary, it's good and bad, and it's power over, and there are the underdogs, and of course that's very much part of it, but there are other dimensions to it. So, coming at this from studying anti-gender backlash, and after I had that, I'm not the only one at IDS studying anti-gender backlash. We have another program as well, Supra, in South Asia, that Deepa leads. We have various other people looking at authoritarianism and related matters. But we've learned the importance of tracing the different kinds of actors and their likely motives behind backlash, as well as how they work and why backlash is so potent in the current moment. And it seems that backlash actors are coming together almost organically and opportunistically with very diverse interests and the different kinds of actors. So it's really important to unpack that and map it out and look at what the different kinds of motives and actors. And they're coming together around crises and opportunistically, a bit like with gender, they're exploiting crises and anxieties and miscontent to mobilize people around very divisive ideas about us and them, taking sides, but also offering more secure futures with very interesting stories about how things used to be and should be again. So they're really using kind of psychosocial power, which could get better. I mean, we could get better in health and connecting with psychology, psychosocial power relationships, and that, of course, is inherent to the patriarchal discipline that medicine is, or health is, where certain branches of medicine are hegemonic over others, so biomedicine hegemonic over all other forms of medicine. And then I'm going toward the end here. So they're very effective because they're using very emotive narratives about simply sex bodies living in traditional families, hierarchically traditional families, in very ordered and bordered nations, homogenized nations, othering outsiders, misfits. And that actually is those are very powerful things for them, reducing gender in health, to women's reproductive health, and population control. Because the role of families is to produce the soldiers for the nation to protect itself against those horrible outsiders. And then, so part of the reason it works is that they have simple stories. They're very emotive, and they're appealing. It's familiar, nostalgic, reassuring fairy tales. And data and evidence, frankly, is not needed. It serves the requirements. In fact, this is kind of post-truth. They don't want data and evidence, and thereby dismantling academic institutions and research. So that's a big challenge for some of these recommendations. Finally, just so what can I ask you? Other than that, this is a big challenge. What do you see as a main challenge for taking the Commission's work forward in today's reality, and maybe kind of reflecting a little bit on this idea that data and evidence and rational argument is not really what works here in terms of, and I'm not saying, of course, the health sector is not going to turn this around on its own, but where do we go as concerned people working on development and health? So thanks.
Thank you. Thank you. Can I just really quickly, I can't see the Q&A that is online, or I can't see any questions. So I'm gonna go to the audience in the room, and then if you do have material coming in that you want to forward over here, just because it's not coming up on my screen. But Sarah, do you want to initially respond to what your first commented on, and then I can sort of ask, or Sarah, to gather some additional questions from the room? Okay, so I'm gonna put you all collectively on the spot that are sitting here, and anybody online, to sort of offer some initial questions or reflections. And hopefully, I know it's quite a lot of material we've asked you to sort of digest, but Dita, you look keen to. So I will turn to you right away. In fact, I'm gonna stand up so I can move the microphone around, because I don't know if we've got a second one in the room. So Dita, I'll let you go first.
Thank you. Thanks, Professor Hawks. That was brilliant and really a lot of ground covered. And I cannot just even imagine the kind of pressures and the competing interests of even the commissioners and the authors, etc. So real congratulations on that. Thank you. My question was about the way that the health sector itself frames not just gender, but women, and how it sort of feeds directly into the hands of these backlash actors by kind of like by mainly focusing on women as conduits of health and education and other things, right? And nutrition. So it's sort of like, you know, that it's not women's own health that matters, but also the fact that they are like you said, the family doesn't provide care for you know, these soldiers. It's women who does, and the very erasure of women as providers of that care, and just going straight as if they were like instrumentalized basically into children's health and children's nutrition and, you know, their families' well-being, etc. Well, the health sector hasn't really played into the very hands of those backlash actors that we are trying to counter. But also, like, so did you find anything specifically about women as conduits and how the health sector frames that?
Oh, yeah.
Do you want to? You can take them as they go.
I realise I'm not as good at typing notes as writing them down, so I'll just respond one by one. And then I'll come back to your question, Johan. So I mean, I think you've really succinctly captured exactly what we found, that the framing of like a really common phraseology that we kept finding the more we looked into health, global health organization literature is it would go something along the lines of women, children, and other vulnerable populations. By the end, it was driving us all completely insane for very obvious reasons. But I think really captures that notion that the way the health sector, the global health sector, has framed women over decades and beyond, is certainly as these vulnerable, weak creatures. If you look at the history of medicine, it's very clear from Aristotle onwards that the female body and the female form, in the form of a woman, is a weak and vulnerable creature who needs saving, often from herself. And a lot of medicine, as practiced as clinicians, until really quite recently, and undoubtedly still is practiced in such ways in many parts of the world, is about a woman as this helpless creature with uncontrolled biology that needs to be saved from whatever she needs to be saved from at that particular moment in time. The other way that health, of course, the global health sector has seen women is as unpaid labourers. So if you look at the construction of health service delivery and certainly social care delivery in multiple countries, the whole idea of community health workers, everybody's, these wonderful women who've delivered vaccines to millions of babies and diagnosed endless amounts of diarrhea and coughs, but we won't actually pay them. So we're going to build an entire system on women's unpaid labour. So and so all of the literature that we looked at, by which I mean the way global health organisations talk about themselves and their work, and obviously the academic literature that analyses that, very much feeds into those two notions, that women are vulnerable and weak and can't sort their own health problems out, so we'll do it for them, and we will decide what their health problems are in a very top-down way. And speaking exactly to what you just talked about, Yoka, that those top-down health problems totally align with what the national demographic and economic goals are. So I think one of the things that became clear sort of over the course of, I think Erica and I have talked about this for years, that the collapsing of women's health to mean family planning, is something really, really clearly laid out in the history of understanding global health and population control programs. It's very easy to do an economic analysis of what gets delivered, and health economists and health philosophers often talk about prioritization of health interventions in economic terms. But it's actually also really clear from all of the work that Eric and others have done, is that those decisions about what a health service will deliver are also driven by demographic goals. And so women then very much are the instrumentalized vessels, literally, of delivering a demographic goal, whether it's pro-natalist or anti-natalist, or keeping the foreigners out through our pronatalism, or whatever it is, that's how women's bodies are viewed. And hence the prioritization is simply what happens from here to here. What's called bikini medicine. Nothing else outside of the bikini area really counts as far as health programs, policies, and practices are concerned in those kinds of environments.
I'm wondering if I should take a few questions, compile, or you do want to keep going one by one, because there's not a formal group, but do other people have questions they would like to ask in the room? Carol has got a question. Here we go.
Thank you. It's been really interesting and enlightening to me. I'm Caroline Kinney. I'm from the digital cluster here at IDS. So we do a bit of research on gender and digitalization. And by default, we've looked at women. And so we have defaulted to the way it's kind of defined. So now I'm asking myself, well, I have a question, and it seems like a simple question, but I saw a list of different definitions. I think you put on the slide. So if I'm thinking of digitalization and gender, how would you define gender in that aspect? Like an example to help me try and kind of conceptualize what would mean in digitalization, for example.
Oh, so, well, first of all, tell me what digitalization means.
Well, it's for example, I think of a hospital that maybe starts a new health program to provide pregnant women with a kind of pathway throughout their pregnancy for the kind of questions and support they'll need each month. So typically you probably have, like traditionally you have women come in and get some advice from a nurse, for example, midwife. But now they have tried to digitalize that process by providing online access to information and interactive questions, in some worst cases AI to support women through their pregnancy. So that's an example of sort of digitalizing education and awareness on pregnancy. That's off my head, so I could be wrong in relation to that. Yeah.
And most of the work that you do is focused on women.
Yes.
Yeah.
Yeah.
So I think that in some ways that question of what does gender mean, the simplest way I think that we ended up trying to describe it in the commission is it means everybody. Whereas coming back to your question, what the global health sector, and I assume that we're not the only sector that has thought about gender in this way. I mean, the work in the education sector says kind of exactly or very similar findings, is that we've only thought about half the population as having a gender, and that men and boys, thinking about gender beyond women and girls is something that development in general seems to have found extraordinarily challenging to do, except to talk about men and boys. I mean, classically in health, you talk about engaging men and boys, often for health outcomes in women and girls. It's like, how many of us ever go to see a doctor because we want somebody else's health improved, unless we're a parent taking a child? So coming back to your question, I mean, it's hard to know the specifics to give a very specific answer, except to say that I think what we're trying to say, I know that what we're trying to say all the way through is to push back against the notion that something like digitalization of health services only applies to a very small part of the population, pregnant women. Or I know you gave that as an example, women of reproductive age, for example, which is a really classic age and gender group for health services. But actually, we're talking about the universality of everybody's health and everybody's gender identity.
Is it used, if I
Please.
jump in on this, is it useful to think about what the word actually means? It's a word in English. It's not a word in a lot of other languages. It came from French, grave, and in the Middle Ages, it came to be used. It means kind. So kind of something, and it's applied to people all of a sudden. And so the question is, how many kinds are there? How many kinds are we? How long is a piece of string? Because we're multidimensional. We have age, we have gender, we have age, we have sex, we have gender identity, we have sexuality, we have class, race, ethnicity. Yeah, so it's a pretty fundamental question, and it goes back to your question actually, and your recommendation, should we be needing or defining a universal definition for gender that is absolute? I mean, because that becomes part of the problem, like you said, in the early ICT, it's as is understood in the country.
Yes, yes.
And how do we get around that problem when it's an English word?
As is generally understood.
Yeah.
So not even as is understood, just as is generally understood, which is, could be a vaguer way of putting it.
And despite its origins, we know that when that first tropical diseases report was introduced into the spaces of WHO, that the French translators refused to translate the word gender, saying there is no such word in our language, we'll only talk about sex. And so over the past 30 years, they have brought the word back in, but it.
Well, and I feel like for historical context, we should explain that when you identified that TDR document, it, as the first of the use of the word gender within the UN health system, this was like high level policy documents, reports or guidelines that were kind of, going out. So it wasn't like all possible documentation, but it was kind of tracing where this then landed when it was sort of at that level of like consensus or guideline and recommendation, policymaking, specific to health. So it existed earlier in other aspects of development, debates, and especially in feminist development economics and agricultural development is being used earlier. And the health sector is a bit more conservative. It took a little bit longer for sort of some of those debates to go into that space, but it's still pretty shocking that it was like 93. It's more recent than people realize that it was kind of being operationalized at that level in that space.
And of course, you probably know this, that the first time the health community really starts to talk about gender is actually the 1950s. Although there's some evidence it might have been a little bit earlier, but it's only in relation to child development. So the origins go right back to psychology, and so it's a famous American psychologist who introduces the idea of the social roles of children as they develop. We'll call it gender.
It started with sex roles, didn't it not? And then it became gender roles.
Well, yes. So there's by the
It's
60s.
trying to find
about
when
sex
the
roles.
concept gender is used.
Yes. Yes, and of course, sex roles is what we've come back to in January.
Yeah.
But when you get rid of gender, you're back to the natural family and sex roles. It's very,
I mean, it does leave me sometimes to question whether or not we're just seeing a backlash or something, a continuity that's taken sort of different, a sort of a rise and a fall of a continuity rather than a, back, of course, but also backlash, the language we use makes it sound as if it's, I mean, of course, its recent configuration is more recent, but I mean, you stretch time this way, and you're looking at this over this long stretch of time, but it looks like instead it's just continuity of blips of some slightly more sort of progressive or radical or reformist notions coming into sort of dominant power spaces like, UN level and prior to the UN, sort of other sort of international health agreements. But the continuity of the limitations of thinking of this in terms of a binaries, that's the continuity. So the social dimensions are, or the capacity of the health space to think about the social and political dimensions is less what you see a continuity around. You see the continuity of, I'm speaking as you don't know this, of course you know this, but it's fascinating though to look at it over time and to realize how few moments of consensus there have been on concepts such as it is now being used here in the commission. I wanted to, sorry, go ahead. Did you want to say something? But I also want to make sure, Santi, Catherine? Us, any other questions from the crowd? Any burning questions you want to ask Sarah? At the back? No? Okay. Did you have something else you want to propose?
No, that's fine.
Well, I was gonna ask.
It's just, in terms of, there's something peculiar about the current backlash, if we call it that, which we do call it, which is mobilizing on the word gender specifically. But it's not all about gender, and so race is very much part of it, and so we had another backlash in the 70s, more or less, which was when the term patriarchal backlash was invented by or coined by Susan Faludi. And that was the context of the civil rights movement in America. So it wasn't just about gender then either. It was actually imbricated in a broader kind of social struggle about equity and justice in the United States in particular, but also here with second wave feminism. But of course, it goes further back. So in the 30s, when we had the rise of fascism, we had identity-focused backlash as well, and then it was more ethnic. But the families and traditional values and role of women were also important and mobilized. They just didn't call it gender then in the same way.
Of course.
But if you were homosexual, you risked going to a camp, and so the issues were still there, and they're imbricated in social justice and inequality solutions. And they used a similar binary device about the pure race and the other races. So it's, yeah, the historicity of it, I think, is so important, and we shouldn't get too hung up on the word gender as a holy grail. We need to stay critical to on it and kind of relate it to history in the making, because we're part of it. Sorry.
Well, I want to give you the last word, but also invite everyone to read it in detail, because I think there's a lot of the richness of the materials difficult to convey. A document with the amount of annexes and references and the invitation to sort of dive deeper to these issues is for everyone. So hopefully those who tuned in online and obviously in the room will take the time to look at the Commission's work in full and engage with it and ask these critical questions that will move these debates forward in time. But Sarah, I want to give you the last chance to make any last question. Not that I can see, unless, no. So we do not have questions online, otherwise I'd be asking them. But yeah, I'm gonna go to Sarah to give you the last questions that you want to.
Yeah, thank you. I think, you know, after such a large piece of work involving so many people, you know, it's kind of, and coming up with so many recommendations. I actually think Jurka and Erica that and everybody that you kind of hit it on the head with well, what difference is it going to make when we are in a time of where we're anti-evidence and post-truth, quote post-truth. And I think one of the things that it's kind of easy to see taking that historical look, but also the contemporary look that we had, or the contemporary view that we had when we started in 2020, was that what we were most concerned about at that point in time were the divisions amongst ourselves. That none of us could agree on what this word meant, what it meant in terms of implications for the work that any of us did, and that we were existing in a very fractured field, which you know in this university better than almost anybody else in the UK. I mean, you know, I know it's not necessarily right in this building, but it's been an ongoing divisive context for all of us, and that was what we were most concerned about. And it's not that I'm not concerned about that. I think it became very clear over the course of the 5 years that actually there's very strong communities of people who are interested in women's health, people who are interested in the health of men, people who are interested in the health of trans and gender diverse populations, or people with other gender identities, but getting everybody to actually work together and fight for equality of or equity in health outcomes I feel like that is where we're still trying to figure out how to make that happen. Whereas we all know that the right, as they've spectacularly shown, don't worry about definitions and that sort of dancing on the heads of pins analogy. They just get on and deliver what they said they were going to deliver. You know, one thing we were asked, we submitted the final version of the report in January this year, and we were asked to make revisions in February, given the political context. And actually, to be honest with you, there weren't that many revisions to make because we spent quite a lot of time reading Project 2025. And so we just, you know, instead of saying this is what's being threatened, it's they did what they said they were going to do. It was right there written on the tin, and it's all being delivered to us. So I would say that my big reflection, sort of, or my final reflection, moving forward is really the challenge, I think, is how do we bring ourselves together at this point, not just around this notion of gender or gender identity or even sex or whatever we want to call it. I'm not that sex and gender are the same, but you know what I mean. Just how do we bring ourselves together as a community and work with other social justice groups? And we're not the only people in the world facing that challenge, but we're really, the more time we spend fighting amongst ourselves, the less effective we're going to be. So I think that those questions or those recommendations at the beginning around how do we develop positive frames that encompass an umbrella for all of us to sit under, for me, that's still the biggest challenge. And we're just not there. I'm not there in the conversations that I'm part of anyway. And so, you know, one hope I would really have is that if those conversations are happening, it'd be great to hear about them, because otherwise it can feel quite despondent.
What I want to do. No, I think it's an invitation.
Note. I mean, I'm going to give a little bit. Sorry, Lindsay, I'm going to refer to you. So I did that slide where we saw a 25% drop off in American organisations' commitments to DEI and gender equality. What Lindsay's been frantically working on. I'm amazed that you came to Brighton now, because I know you're frantically in thousands of data points in Excel sheets right now, is to go across our entire sample of 200 organisations again. And actually what we're seeing, I hope you don't mind me doing a spoiler alert, but we are seeing that it's an American problem. The rest of the world is actually standing pretty firm. Which is fantastic, which is a positive. No, I'm sorry, the Americans. But because actually we've got our principles, and yes, of course there are problems, because there are always problems in the world, and there's always, as Erica's work has shown, there's always been backlash, because we haven't managed to convince everybody with just how brilliant our arguments are of not having backlash. But actually it's not bad. Yes, we need better stories. Yeah.
All right, well, everyone in this room gets to work on those better stories, so we can reframe the narrative and spur everyone towards common consensus on gender justice goals and outcomes. So work for everyone to do in the future. I just want to thank you again for taking the time to come and talk to us, and also to Lindsay for coming, because you put quite a lot of work in this commission that not have been possible without you as well, and to my colleagues who've come to engage with this work, and to Jürgen for providing his reflections from the Countering Backlash program. So thank you, everyone.